Yes.
Yes.
Okay. Well, thank you for the invitation. In this presentation, I will deal mainly with or only with Chiari malformation. First, I am going to divide my presentation into three parts. First, I will talk about what we do in our program. Then I will show what the international guidelines teach us. And finally, I will outline a flow chart on when to consider surgery. First, let me give you the specific thresholds or red flags used in our program that alert us that surgery may be necessary. First, posterior fossa crowding in MRI. Also, tonsillar descent below the foramen magnum. But remember that the degree of descent alone is not an indication for surgery. Also, the presence of syringomyelia, and finally, evidence of increased CSF velocity at the foramen magnum superior to 5 centimeters per second. In spite of the red flags, not every patient requires surgery. Our decision for surgical intervention is always based on a combination of three items. First, progressive or severe symptoms like the classical occipital or suboccipital headaches and neurological dysfunction. Second, the presence of syringomyelia, especially if progressive or symptomatic. And finally, the evidence of obstructed CSF flow on phase contrast MRI. We think that the increase in CSF velocities is more significant than the absence of flow in the posterior fossa. We consider that the following are not indications for surgery, classically symptomatic patients and also patients with mild stable headaches. Unfortunately, we do not have clear levels of good evidence to guide our conduct. The strong evidence from meta-analysis and randomized controlled trials are lacking. Therefore, it is wise to analyze the main guidelines or official consensus of the international societies. Here, I will mention three of them: the European Consensus, the Congress of Neurological Surgeons, and the World Federation Spine Committee. Here are the papers where you can read the more recent guidelines or recommendations of these three consensus. As a summary, these guidelines point out that always symptoms drive surgical decision-making. The presence of syringomyelia is a strong indication overall in pediatric patients. That the study of CSF flow help us in borderline cases. We must perform fusion in cases of C2, C1 dislocation, and of course, in asymptomatic patients, you must leave them and only make a thorough follow-up. Here is a brief or concise flowchart of surgical indications based on our experience and the consensus guidelines. We can see that in symptomatic patients, we always consider surgery overall in typical cases, also in patients with basilar invagination with or without C1, C2 dislocation, and in atypical cases with mild symptoms, it's important to measure the abnormal CSF flow. In cases that are not symptomatic, in asymptomatic patients with syrinx, if we consider surgery, especially if it's a pediatric patient, to help to prevent scoliosis. In asymptomatic patients without syrinx and a normal CSF flow, we only observe. Finally, we can say that the decision to operate is primarily driven by the presence and severity of symptoms and the presence and progression of syringomyelia. In asymptomatic patients without a syrinx are managed conservatively with observation. Thank you.
Thank you very much.